Hello, everyone, and welcome to today's webinar, PACE 2.0, Expanding the Reach of a Proven Integrated Care Model for Older Adults. Before we get started, I'd like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by telephone or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in the control panel to the right of your screen. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of the presentation. The presentation does include a video. If you are only connected through telephone, you will not be able to hear the video audio. The video link is included in the slides, and we would invite you to watch the video after the webinar. I would now like to introduce John Feather, CEO of Grantmakers and Aging and moderator for today's webinar. John?
Well, thank you, Joy, and thank you to all of us for all of you for joining us today. We want to thank, as we begin our presentation today, West Health, who organized today's session on this important topic, and the John A. Hartford Foundation, who supports our monthly webinar series and allows us to provide it to our audience free of charge. I'd like to start today by introducing Amy Herr, who will moderate the discussion. Amy is the Director of Health Policy at West Health Policy Center, a part of the West Health family of nonprofit organizations dedicated to lowering healthcare costs and enabling seniors to age in place. Amy is a state and federal policy expert with a focus on long-term services and supports. She leads West Health's work to support the expansion of the program of all-inclusive care for the elderly, or PACE, a Medicare-funded care model that enables seniors who need nursing home care to remain in their homes. We'll learn more about this successful integrated model of care and how it is poised to grow in today's webinar. Without further ado, I'd like to turn it over to Amy for our discussion. Amy?
Thank you, John, and thank you to Grantmakers and Aging for hosting our call today. I'm pleased to welcome you to the discussion. Today we'll learn about PACE and how to help expand the reach of this person-centered integrated model of care. So many more seniors could benefit from PACE, which, in addition to vastly improving the quality of life for participants, also has the potential to lower cost of care. As John noted, I'm the Director of Health Policy at the West Health Policy Center, solely funded by philanthropists Gary and Mary West. The Policy Center is a nonpartisan nonprofit based in Washington, D.C., and is part of West Health. West Health is a family of nonprofits that's focused on lowering healthcare costs and enabling successful aging for our nation's seniors. Gary and Mary West believe strongly that seniors deserve better care, and one of the senior-friendly models that we are advancing is called PACE, the Program of All-Inclusive Care for the Elderly. Everyone on this call knows that there's an incredible need for more senior-friendly care in our nation, and PACE is one very effective model, keeping seniors who need complex care out of hospitals and in the comfort of their homes. I'm very excited to hear from our speakers today and share more about PACE and how funders can engage. First, Peter Fitzgerald is the Executive Vice President for Policy and Strategy at the National PACE Association. Peter leads the association's federal and state advocacy efforts and supports strategic priorities such as the PACE 2.0 initiative to expand access to and use of PACE across the nation. Prior to joining NPA, Peter served as the Senior Vice President for Integrated Care Strategies at Volunteers of America, where he was responsible for planning and development of new PACE programs. Next, we'll hear from Ursula Robinson, the Executive Director of PACE of the Triad in Greensboro, North Carolina. She oversees all PACE program operations, including medical, clinical, financial, and supportive services. Her team of 82 staff serves more than 200 PACE participants. The PACE of the Triad piloted the National PACE Association's PACE 2.0 growth initiative, and Ursula serves as a resource through NPA for other programs that are looking to grow. Tom Reiter is the Executive Director of the Gary and Mary West PACE Center, which is slated to open this year in Northern San Diego. Tom has worked with 4 PACE programs in different parts of the country over nearly 20 years. Like Ursula, Tom also serves as a faculty for the PACE 2.0 initiative, helping other PACE organizations grow. And Tom is also a member of the National PACE Association's Board of Directors. Thank you all for joining us today. Next slide. During our time together today, we'll hear from Peter Fitzgerald about the PACE model, where it stands now, and how NPA, with support from West Health and the John A. Hartford Foundation, is working to bring PACE to more older adults who would benefit. Ursula will share her team's experience field testing the PACE 2.0 growth tools, and will share early results from their work. Tom and I will discuss West Health's support of PACE, both nationally and locally, and we'll share opportunities for philanthropic supportive efforts to grow PACE in local communities, regionally and nationally. We hope you use this opportunity to ask questions of our speakers, and then we can help spur ideas and action in support of new or expanded PACE centers that can help many more seniors around the country. Next slide. And with that, I'll hand it over to Peter Fitzgerald from the National PACE Association.
Great. Thank you, Amy. And I'd like to add my thanks to everyone on the phone today for taking the time to hear more about PACE and giving us this opportunity to share with you the opportunities for growth that we see in the program. I'd also like to especially acknowledge the support from the West Policy Institute and from the John A. Hartford Foundation for the PACE 2.0 initiative, which is guiding so many of our efforts to support growth of PACE nationally. As Amy said, I'm going to give a profile of the PACE program and the people that we serve, and talk some more about where we see growth going and how we can accelerate the pace of growth for PACE programs nationally. If I could get to the next slide, please. PACE is a proven model of care that goes all the way back to the 1970s, when the care model was first developed by Onlock for the Chinese American community living in San Francisco. And the origin of the program was a simple idea, the idea that in that community, families did not want to have to send their seniors, their elders, out to a nursing home. They wanted to find a way to care for them at home. And what began as an adult daycare model grew over time to include the full range of care services that we all know frail elders need, which are not only medical services, primary care, acute care services, but also services to support living in the home, services that address some of the important social determinants of health, and services that are able to integrate all of that care in a way that is able to view the individual holistically. I wanted to highlight some of the points of information available to you here on the slide. 100% of the people who are in PACE programs meet their state's nursing home level of care criteria. However, because PACE is a program intended to enable people to live at home, 90% of the people in PACE at any given time are in fact living in their own homes, and they're able to do that with the support of the PACE program. You can see that there is a high degree of frailty, dependencies, and activities of daily living in the PACE population, and that frailty combined with multiple complex chronic illnesses creates the complexity of need and care that the PACE programs are responding to. It's also worth noting that within the PACE population, about 50% of the people being cared for have some form of cognitive impairment. And we're seeing more and more, as the program has grown, an increase in the younger cohort of PACE participants. And I personally appreciate the fact that the younger cohort is people aged 55 to 65, an age that I'm not that far away from, so it's nice to be in a younger cohort. But in that 55 to 65-year-old cohort, we're seeing an increasing number of people with behavioral health and substance abuse issues, and so those needs are becoming a bigger and bigger part of the care that is being provided within the program. If I could go to the next slide. The PACE program is comprehensive in the services that it provides. So the name Program of All-Inclusive Care for the Elderly is actually very descriptive. Often when I'm trying to convey the scope of services within PACE, I encourage people to think about what might not be included, because when it comes to healthcare and long-term services and supports, really everything is included. So what's not included is the PACE program is not allowed to pay for the expense of housing. But what is included is everything from primary care, in-home care, hospitalizations, nursing home time if that's needed, either for a short-term rehabilitative stay or if a person's health declines to the point where they need to be in a long-term nursing home stay, transportation, activities, social work, nutrition. Many of our programs have pastoral counseling as part of the team. So it's really a fully comprehensive model designed to address the full range of needs of an individual. Most of the individuals enrolled in PACE are covered by both Medicare and Medicaid, so about 90% of PACE enrollees are dual eligibles. Another 9% are Medicaid only, and we have a very small number of people who are Medicare only, and I will talk about that as an opportunity for growth a little bit later. In addition to caring for the participant who is enrolled in our program, PACE programs spend a lot of time looking at the needs of the caregivers who help us take care of those participants. So there are services including respite care and support groups, training and education to work with participants' caregivers and support them in their role. We just recently completed a caregiver satisfaction survey of family members of PACE participants, and the results were extremely encouraging. Overall, family caregivers reported a 37% decline in the reduction in their caregiver burden, so they're experiencing caregiver relief. 96% of family caregivers reported satisfaction with the program. 97% of caregivers would recommend the program to somebody else, and 90% said that the PACE program enabled them to be a better caregiver for their loved one. So caregivers are integral to what we do. So many of because our people are living at home, many of them are reliant on those family caregivers to supplement the care available through the program. And you can see in the visual here the range of services. I wanted to highlight meals as an example of paying attention to those non-medical determinants of health, really taking a look at nutrition. And I wanted to highlight as well the fact that the services are provided across a number of settings. So they're provided in the home, in the PACE center. If a PACE participant goes to the hospital, the PACE care team is looking after that individual while they're there and facilitating their transition back to their home. And because we're providing that care in all of those settings, it gives us a very holistic view of the person's life and needs, and therefore we're able to better respond to their care requirements. If I could go on to the next slide, please. I mentioned there that we have a team in the PACE program, and the PACE interdisciplinary team is critical to the PACE program's effectiveness. The members of the team represent the full range of services available to the individual, and I think what's notable about this interdisciplinary team is it is comprised of people who have a direct care relationship with the PACE participant. So the same team members that are assessing care needs and developing care plans are the team members who are delivering that care, and that creates this very real-time, very informed, and very holistic view of a PACE participant, which improves the effectiveness of the care that's delivered. I wanted to offer an example of this. I was recently observing a PACE interdisciplinary team, and one of the team members noted that this particular participant, who normally was very engaged and liked coming to the PACE center, had not gotten dressed, indicated that they didn't want to come to the PACE center that day when the transportation vehicle had come to pick them up. And the social worker observed that she had noticed this participant had been depressed and had been talking a lot about wanting to see his mother, who lived in Puerto Rico. This participant lived in New York, but because of advanced dementia, travel was really not an option for this participant. And the team, in brainstorming around how to address this need, came up with the idea of setting up a Skype connection so that the PACE participant could visually at least see this parent who was far away. And I think that's a good example not only of the creative problem solving that's enabled through this comprehensive interdisciplinary team, but of the way that a problem that might seem isolated, participant did not attend the PACE center, can really be linked to all of the other things going on in that individual's life and can be linked to all of the other services that can be provided through the program. I could go to the next slide. There have been a number of evaluations of the PACE care model, and I think not surprisingly, given its design, it generates a high level of quality of care and quality of life for the participants in the program. Research studies have shown that PACE participants will experience fewer hospitalizations, fewer emergency room visits, and have fewer unmet needs for their care than comparable populations in other forms of care. And at the same time, PACE participants are experiencing more years of life and a higher quality of life. If I could go on to the next slide, please. Because a lot of this is more meaningful when viewed through the experience of an actual family member or participant, we wanted to share with you one of the videos that is from a series of videos called Before I Found PACE. And in this series of videos, we took the opportunity to ask PACE participants or family members, and in some cases both, what was their life like? What kind of care were they experiencing? What kind of quality of life were they experiencing before they enrolled in the program? And here we have an opportunity to hear from one of them. If we could play the video.
In America today, almost 1.4 million people live in a nursing home. Many of those people could be served in the community if they and their family had access to appropriate care and services. While everyone enrolled in programs of all-inclusive care for the elderly, or PACE, need a nursing home level of care, 95% of PACE enrollees live in the community. Phyllis Benning thought she might spend the rest of her life living in a nursing home, unable to walk, before she found PACE.
If I hadn't found PACE, my life would probably be in a nursing home, or either I would have to go live with my son.
She had several strokes that put her in a nursing home facility around January of 2016. And Fee had been there that entire time. The strokes had rendered her physically dependent completely.
She was not able to walk at all. She was completely dependent with care, pretty much. And so she came for intake assessment because she wanted to go home. She owned her own home. She realized that our physical therapy department was top-notch and they might be able to help her walk again. So it became her dream that she wanted to go home.
Mrs. Benning was a very motivated, very determined lady. She would make progress. Every month she would do something new.
All I needed was a chance to just stay in my house, and that's what PACE allowed me to do.
She made huge progress. She started standing that summer with our standing frame. By that fall, she got to where she could take a few steps. Then she graduated out of her Tilton Space wheelchair into a regular chair. Still that fall, she started working on steps. Then she started walking. Her wanting to try everything that she possibly can try was what she wanted to do. She wanted to get better, and she just had a taste for it. By that Christmas, she was walking, she was doing car transfers, getting in and out of a car, going up and down steps.
She went to the church where her mother was, and she was on her walker, and she walked in the door, and it was like most country churches, you enter from the back of the church, and it was double doors that swing open. And so her mother was there, and a camera was on her mother, and her mother didn't realize it was Fee because she never expected her to walk. And when she looked around there and realized it was Phyllis, her mother broke down in tears and put her face in a songbook.
She has worked so hard with our physical therapist, but we have really gotten to be, well, she's like family for us, and it has been a joy to watch Fee and her spirit, and to just watch her progress from being fully dependent to somebody who can now kind of live that dream of traveling to Washington, D.C. to watch her granddaughter graduate.
PACE has been wonderful for us. It's the best thing that could have happened to me.
To find out more about how organizations like yours can help thousands of people in nursing homes like Phyllis, visit the PACE 2.0 website. That is pace2-o.org.
Great. Thank you. And it's nice to see the technology working seamlessly. Very impressive. I want to turn to what we see as the future for PACE, and it's a remarkable program that has demonstrated remarkable results. And we know that there are many reasons to increase access to and use of the program. When we look at the experience of people like Phyllis and others, we know that many older adults feel isolated, bored. They don't want to be dependent on others, but they feel that they're in danger of that. They have difficulty accessing care. The care that they can access is uncoordinated, and many have a real fear of nursing home placement. And for family caregivers, what we hear and see is that they're worried about their loved one and how to provide care for them. They're worried about how they're going to keep their own lives together, keep working and keep taking care of their own families. They're tired. They find that they're running around a lot to get their loved one to care, and it's very hard for them to maintain a work schedule. So the reasons or the why for growing PACE, I think, are numerous and important, and that's what's led us to take on this PACE 2.0 initiative and really take a hard look at what we can do to expand access to and use of the program. Nationally, of the roughly 2 million people who are low income and have a need for long-term services and supports, only about 2% of those people are being helped by PACE. That's in part because PACE is not available in many states. There are 19 states that have not yet opted to include PACE as a benefit, and because PACE is a Medicare and a Medicaid program, if PACE is not included as a benefit on the Medicaid side, it's not possible for a new program to get started, even if that program were going to serve people with Medicare benefits who don't have Medicaid. And lastly, there are other populations beyond the currently eligible population that we think could benefit from the PACE model of care. So other populations with similar levels of frailty, similar levels of complex chronic illness, and I will talk a little bit more about them as well. So through PACE 2.0, if I could go to the next slide, we have set a goal of expanding from the roughly, it's 50,000 now. I think we might have had an earlier slide that said 45,000. That we just recently looked at the January enrollment data, and it looks like there's about 50,000 people in PACE today, and our goal is to increase that to 200,000 by 2028. And we see three ways of doing that, or three different sources of growth. One is to expand the number of people that PACE organizations currently operating or serving, and to work with them to give them tools, tactics, and techniques to accelerate the rate at which they're able to grow and serve more people. A second source of growth is to promote and support the opening of new PACE programs in new communities. In many cases, the reason people are not enrolled in PACE is simply because there is no PACE program in their area. So how do we get new PACE programs serving new communities? And the third area is looking at this expansion of PACE to new populations. And specifically there, we could see making the program more accessible and affordable for individuals who only have Medicare. So Medicare-only individuals would be one expanded population. Other types of expansion populations would be people under the age of 55 with physical disabilities or cognitive disabilities who currently can't enroll simply because of their age. And then there may be people who are not yet at a nursing home level of care according to their state's criteria, but who are starting to experience this combination of chronic illness and limitations in their activities of daily living, for whom the program could be helpful. And an example of that might be an individual with early stage Alzheimer's disease who might not yet be at that nursing home level of care, but could use the support of a program like PACE. So if I could go to the next slide, please. To promote growth in those areas, we are going to be using a methodology originally developed at the Institute for Healthcare Improvement, where we go and we look for examples of PACE organizations that are currently achieving rates of enrollment, rates of growth that are consistent with what we would need to achieve in order to meet our aim. Specifically, we looked nationally for programs that were enrolling somewhere between 10 and 15 new people, or net people rather, a month, or had a market penetration rate of 20%. And by that we mean they were serving 20% or more of the people in their service area who needed long-term services and support. From those programs, we developed a growth model that we were able to test, and I'm really looking forward to handing this off to Ursula, who can tell you about the field test of that growth model and her program's experience with it. We are further testing and refining the growth model through a West Coast Learning Collaborative that is supported by the Moore Foundation. Wanted to thank them for that. And that's a year-long learning collaborative with 8 PACE organizations in California, 1 in Washington State and 1 in Oregon State, to implement the growth model and achieve accelerated growth. In addition to the learning collaboratives, we have technical assistance resources that will be available broadly to all of our members. And specifically this week, we'll be sending each PACE organization a growth aim packet specific to their service area that will give them information on the market demographics in the area that they serve, the number of people that they could serve, considerations that they need to take into account for growth, such as their own internal resources, their access to capital. The purpose of this growth aim packet is to ask them to set an ambitious and achievable growth aim so that they can contribute to enrolling 200,000 people by 2028. And with that, I think I'll stop. I think we're going to take questions at the end, and I'll turn it over to Ursula Robinson. Ursula?
Thank you, Peter. As Peter mentioned, my name is Ursula Robinson, and I am the Executive Director of PACE of the Triad, located in Greensboro, North Carolina. PACE of the Triad was very excited to field test the 2.0 growth strategies from NPA. Our organization represents the average PACE program across the country in our size. We were also not meeting the very conservative market penetration rate that we should have been meeting at the time that we were considering 2.0, which essentially means that many individuals within our community who qualified and would benefit from our program were not receiving it. Therefore, when the opportunity presented itself, as the executive director, I volunteered to test the strategies for growth, but more importantly, we were interested in access. Next slide, please. Let me tell you just a little bit about who we are. We are a not-for-profit joint venture created by 4 like-minded nonprofit organizations, which represents a health system, a continuing care retirement community, a home health agency, and a hospice. We are located in a county of 2 large cities, Greensboro and High Point, which creates its own interesting dynamic. Our service area consists of 2 counties, 1 urban and 1 rural. Prior to opening in 2011, our feasibility study revealed that we had the potential to serve up to 5,000 eligible individuals in our service area. As you can see from the slide, at the time that this slide was made, our census was 207. However, as of February 1, our census will be 230. Next slide, please. As the field tester for the 2.0 growth model, or we call it the driver diagram, the focus was on 4 core areas. The first area was culture, looking internally at the organization to see what the culture was like, what the leadership of the culture was like, and what needed to change in the culture to embrace what the 2.0 strategy was trying to do, which was significant growth. The second area of focus in the testing phase was the pipeline, looking at how do you create a pipeline for enrollment to PACE, because unfortunately, PACE is not necessarily an easy program to enroll in like many other healthcare organizations. It's not you call one day and you enroll the same day or the next day. It on average can take 30 to 45 days to enroll in PACE. And the third area we focused on was actually enrollment, looking at the process of our enrollments, but as well as our disenrollments. And the fourth and final area that we focused on was readiness for growth. What internal strategies do we need to do to be prepared for this? And one of the things in readiness for growth we realized is that we were waiting to build when they came instead of building and waiting for them to come. I'll say that again. We were waiting for them to come before we build instead of building and then waiting for them to come. So we had to look at our staffing patterns. We had to look at our processes that we had in place to determine what we needed to do to make sure that we were ready for growth. The tool that MPA provided to us allowed us to document our process. It encouraged accountability, and it promoted teamwork. So we were quite thankful for that. And as you can see from the slide, out of the 3 months that we tested the tool, we certainly met that very ambitious goal of a net 10 a month. And Peter mentioned earlier that you want your goals to be ambitious and obtainable. I think I stretched a little bit for our organization, particularly because of where we were prior to the project. But I'm excited about it. I'm still excited about it. And we kept the 10, and we are marching on. Again, you can see that the most powerful thing for me for our organization is that prior to the testing in 2.0, we literally were not growing. However, after 2.0, we have been growing and growing substantially. Next slide, please. Many of my colleagues asked, how did we do it? And PACE of the Triad was fortunate to begin the 2.0 work actually on fertile ground. Prior to 2.0, we had, if you will, sowed the seed for change in our culture by instilling the need for change first in our values. And one of our values that's been with our organization since day one was the value of innovation. The next thing was making sure that the staff had the leadership support at every level of the organization to support and encourage growth, quality, and change. Another seed that had already been planted in our organization was frontline ownership. basically making sure that there was representatives from every level of our organization who we identified as change navigators and who could, in fact, implement change at what we call the ground level. Finally, I would say that we were able to do it because change is truly in the fabric of this organization. Ever since inception, we have set aside a day to bring our staff together each year to reiterate the organization's missions, values, vision, but more importantly, our dedication to supporting change. So it really was, or really is, who we are, and that it's in our fabric. Okay, I'll turn it back over to Amy.
Great. Thank you, Ursula. It's wonderful to hear about the great success that PACE of the Triad is having in reaching more participants. And you had the great success during the field test, but also since then, you've continued to have good success. So we're really, really pleased by that. And we know that these tools are working for PACE organizations. I also want to thank Peter again for that great overview of PACE and our efforts to expand this program to help more seniors. We are going to be fielding questions at the end of the call. So for the audience, please share any questions or comments that you have for Ursula or Peter in the webinar Q&A feature. But right now, Tom Ryder and I would like to share a little bit more information about what West Health is doing to support PACE and the investments that we've been making. Next slide. Peter's already talked about PACE 2.0, but just as a bit of a refresher, we know that only 2% of eligible seniors are currently enrolled in PACE, and that is shockingly low. And at West Health, we believe that expanding the reach of this program could do so much to help older adults have a better health and a better quality of life. And that's why West Health is partnering with the John A. Hartford Foundation to fund the PACE 2.0 initiative that we heard about today. We're bringing PACE to 150,000 more people, so it's going to be a great effort over the coming years. PACE 2.0 has already identified the essential elements of PACE. We were trying to figure out as we grew what were the key elements that we had to make sure we didn't lose. And we worked on these growth tools that you've heard about and are really working to expedite the dissemination of these tools to all the PACE organizations around the country. And I'm glad to hear Peter saying that's going out this week. I also wanted to thank the Gordon and Betty Moore Foundation for funding the West Coast Collaborative. They're using the same tools that Ursula used at PACE of the Triad and are working with the 10 program collaborative to really rapidly test and implement those tools and learn from each other. So we're really pleased that that's happening. And we're delighted to accelerate the growth through sharing of best practices over time as well. Now I want to turn it to Tom Ryder to tell us about West PACE.
Great, thank you, Amy. It's a pleasure to be here today. A little bit about how we landed on starting the Gary and Mary West PACE program in North San Diego County. It really is, with all the research that the Institute has done and the mission of the foundation, West Health landed on wanting to stand up one of potentially many PACE programs across the country, as they agreed it is the gold standard of care. In our current operations, we're, as Amy said earlier, planning to open sometime in 2019 as we get to late spring or early summer. And we built a state-of-the-art 20,000 square foot PACE building, which will house our interdisciplinary team, as well as one of the unique features as we have embedded a dental center, as the West Foundation and West Health has stood up a dental center in downtown San Diego that's a charitable dental center serving the homeless and the frail elderly. We embedded a 4-chair dental suite inside of our PACE program, which is going to make it fairly unique. As you can imagine, the dental needs of the frail elderly are extensive when they're forced to look at, do I buy food, do I buy my medicine, or do I get my teeth taken care of? teeth end up being third on that list, if not much further down. So we're really excited to have the opportunity to partner with our our dentist who practices in geriatrics to lead that area of our PACE program. As well, the dental center will have the opportunity to serve the community at large to meet the needs of the low-income, frail, elderly population. We've looked at one of the unique features that West will be bringing to PACE Innovation is that we have a research institute behind us that has done amazing work across the nation over the last decade. And we're looking at ways that we can enhance what we've known from the PACE model for the last 40 years. And some of the particular areas, as Peter mentioned earlier, one of the growing populations that are enrolling in PACE are individuals with behavioral health, especially the 55 to 64-year-old population, as across the country, their needs are not getting met in the community. So in addition to getting all of the other support services and medical services that PACE offers, we're going to look at building a robust behavioral health component to our program. Historically, when the model started, we were used to treating the 82-year-old little old lady who had a little bit of dementia, some chronic conditions, and was quite pleasant to manage. And I think especially over the last 5 to 7 years, we've seen the numbers increase in the behavioral health population and a younger population. We're also looking at ways we can implement appropriate telemedicine and telehealth into how we deliver services, and testing and trying to come up with efficiencies in reduction of transportation, being able to quickly access a specialist via an iPad or a video consult with the primary care doctor who's sitting with the participant. So we have the ability to look at what's currently being used across the country, not only across medicine, but in PACE programs, and partner with other PACE organizations to field test and look at the benefits of appropriately deploying telehealth into the PACE program. We're also looking at nutrition. I think that was one thing that Peter mentioned, that we've done a lot of work across the country with different entities on nutrition for older adults and the role that plays not only in their overall health care, but also their dental care and access, some of the social determinants that are challenges that our older communities or older individuals experience across the nation. We're also focused on end-stage renal disease and opportunities there. That is not a preclusion for someone to enroll in the PACE program, and you will see a variety across the country of how many folks with end-stage renal disease are enrolled in PACE programs, but we feel it's a real opportunity to reduce costs when people miss appointments to get their dialysis, that it leads to higher cost institutional settings, be it the ER, the hospital, or nursing home stays. So those are some of the areas that we're focused on right now as we get up and running, and we're really excited to have the support of the Institute behind us to be able to look at establishing new best practices. As the team has talked about, a lot of the area we're working on 2.0 is taking best practice from across the nation and helping organizations adopt and embrace the 2.0 work. But we're also thinking about the future and where opportunities might be to just continuously evolve and enhance what we do in the PACE world. Amy?
Great, thank you, Tom. We look forward to the opening of the PACE Center later this year. So in the last 15 minutes of the call, we wanted to talk with everyone a little bit about what funders can do, how Grantmakers can engage with PACE. One of the great things
Thank you so much.
PACE, oh, sorry. One of the great things about PACE is that it's not a new idea. This is a long-standing, proven model of care that helps improve healthcare and social services for seniors in your communities, and we hope that other funders will be interested in supporting the program. And so we just had a couple ideas about ways that different funders could play a role. At the local level, I would encourage you to learn more about PACE and the programs in your community. So find out if there is a program in the community and whether there are opportunities for philanthropic support. You might consider supporting a specific service, such as purchase of a new van to help with transportation, or financing of a strategic planning retreat for the staff. And if there's no PACE organization in your state or community, reach out to Peter at the National PACE Association and learn about how your organization might be able to help create one. Funders can also support regional learning collaboratives. We talked about the West Coast Learning Collaborative model that we have currently operational. And depending on your level of giving, you could fund an entire collaborative or perhaps partner with other funders in your area or support the participation of one PACE program. And again, Peter can help connect you with those opportunities. And then finally, at the national level and state level, we would like to see continued investment in PACE 2.0 and continued work around the state and federal policy barriers to expansion of PACE and see if we can work on those. So Peter, Ursula, and Tom, I wanted to invite you to offer some other ideas for supporting things that Grantmakers can do to support PACE.
Thank you, Amy. This is Peter. You covered a lot of the ideas that I think have the most promise. But maybe just I would add in some details around working with a local PACE organization. A local currently operating PACE organization often needs help from foundations and funders to extend its capacity, as Ursula said. You know, one of the key factors in achieving accelerated growth for PACE organizations is investing in the capacity before you have the growth, because if you don't, often the program will not be able to receive the growth that might be there from the demand in the community. So you could help a currently operating PACE organization expand the space that it has for its PACE center. You could help it, as Amy said, add vans to its transportation system. You could help them upgrade their information systems. There's a lot of data and information required to manage a PACE program. And actually, many of the growth strategies are very dependent on the feedback loop that comes from looking at the data. And you could even support them to hire some staff in advance of when they might actually have participants who need that additional staff. So just generally supporting the organization as it forecasts its growth and putting in place the needed capacity for it. I would say those things. And here at the national level, in addition to the ongoing work of PACE 2.0, we've talked a lot about the work that's going into supporting currently operating programs. We're really going to be turning to what we can find as fast start models for new programs, looking to develop a similar model, growth model for them, and disseminate that. So that's in our near-term future. And I wanted to emphasize Amy's point about working on state and federal policy barriers. It's a Medicare and it's a Medicaid program. It's critical for PACE programs to have the support of their state Medicaid agencies. It's critical for states to understand how PACE fits with the many other long-term service and support initiatives that we know are taking place in states. And we'd like to be able to do more with states to support them in that. So I'll stop there, and maybe Tom or Ursula has something they'd like to add.
Yeah, hi, this is Tom Ryder. Building on what Peter said, I agree 100%. As a PACE operator for almost 20 years, looking to build out on our capital investment, our infrastructure, our systems, our processes to find efficiencies to work more cost effectively is really critical. But I would also add that support of community outreach and education is really critical. I've heard too many times over the years that you're the best kept secret in whatever city. And there's a lot of opportunity to continue to educate the community, as well as our leadership in the state and the federal government about the PACE model. So there are a lot of opportunities to engage with your local PACE program for those efforts.
I totally agree. This is Ursula, and really don't have anything else to add. Those are great suggestions on how you can impact and engage with PACE. Thank you.
Great, thank you all. And we'd also like to be a resource for you. If any funders would like to discuss PACE with other GIA members, please feel free to reach out to Vian Nguyen at the Gary and Mary West Foundation or Amy Berman at the John A. Hartford Foundation. Both Vian and Amy know a lot about PACE and can speak to our investments and how the impact that we've made, but also what you can do as well. Next slide. Great. With that, obviously feel free to reach out to any of our speakers as well. And with that, I'd like to turn it back over to John for questions.
Well, thank you very much. It's wonderful to hear this update and all the exciting new developments that we've had. We have a lot of questions, and we're not going to be able to get to all of them, but we will be passing these along to our speakers and to get their responses later before I come back to them at the end to get their final words of wisdom. So let me start with a couple of questions specifically to Ursula. Could you talk a little more about the process of how you decided which partners to use and how that was done?
Could you repeat the question, please?
Sure. The question is, when you did the process of developing the program and you decided on which partners you were going to use, how did that process work? How did you put the group together that came together to create this at the local level?
Okay, the joint venture. I actually was employed at the time with hospice here in our local area. I've been employed there for 18 years as a senior VP, and we had connections with each one of the other three organizations that I mentioned earlier. And it actually was the president of the health system that had been to a PACE annual conference for the first time and was hearing about PACE for the first time and came back to Greensboro on fire about what the potential that this program has in our community. You may at this time, it was a period where hospitals were about to start getting penalized for readmissions. Again, all four of the organizations are nonprofit organizations, so they are committed to the community. They saw opportunities to serve people that their traditional organizations, for example, the continuing care retirement community and the hospice, may not reach because they're either not at end of life or they are not do not have the means to be cared for in a continuing care retirement community. So I really think it was the commitment to the community. But more so, these 3 or 4 partners were already affiliated with each other in some form or fashion. So we all knew each other going into this, but it certainly was the health system's president that pulled us all together.
Well, thanks for that. Peter, is there a question for you, I think? And you mentioned in your comments that it's important to continue to inform, particularly in states where there's not a great deal of activity or the state has not decided to participate in the program. Could you talk more specifically about some of the strategies that your organization uses around getting states to become engaged in this?
Sure. I think what we've been trying to do in our conversations with states is help them position PACE within the overall context and range of options that are available to people who live in the state. And I'm sure many of the people on the call are aware that there's been a market transition from home community-based fee-for-service types of services in long-term care to more managed long-term services and supports under more of an insurance model. And what we really find is most helpful when we're talking to states is to show how PACE can complement those other efforts. Those other efforts tend to be on a much larger scale, regional or statewide. Managed long-term service and support insurance programs rely on networks of providers rather than being provider-based. And they don't have that direct care relationship between the interdisciplinary team of the PACE program and the PACE participant. So I think we feel that it's important for us to help states understand how PACE offers consumers a distinctly different alternative than being enrolled in an insurance plan. And the other thing we've really been paying a lot of attention to is options counseling. As the range of options for getting coverage of long-term services and supports has increased, it's also become more confusing in many ways. And we've been concerned that when people access options counseling services, that those services don't always have a full understanding of PACE in particular, but more broadly of what are the options available to an individual. So for the past 3 years, we've done a mystery shopper research study of options counseling programs, where we have mystery shoppers talk about a family member who needs long-term services and supports and go through that options counseling process. And in general, what we found has been, I would say, concerning. Often it's difficult to access those options counseling services, and when people are able to access them, we find the options counselors are rarely well informed about PACE. So we're working a lot with states as states roll out and expand their managed long-term care options to make sure that those options counseling services are more robust, more informed about PACE as an alternative to those other options. We also work with states around making sure that they can do rate setting for payment of PACE programs in such a way that the programs are giving them good value. We study state rates across the country and find on average that PACE programs are paid 13% less than states would have otherwise spent to take care of a comparable population through their HCBS and other long-term service and support options. And I'm sorry, I lapsed into the acronym, but for those unaware, HCBS, Home and Community-Based Service Alternatives.
Thanks so much. And unfortunately, we're coming to the end here. I do want to return back to all of our speakers for their final words of wisdom for our audience. And Tom, could we start with you?
Sure, yeah. I think one of the other opportunities is many states, as we see PACE scale and spread and add new locations in states, we have seen an increase in PACE state associations, and that's another great opportunity to support the growth and the scale, the education outreach to the community. So thank you for your time today.
Ursula?
Thank you. I would just say adopt a growth mindset, build it and they will come. Make sure that you have the infrastructure in place so that you're ready for the growth, and that infrastructure certainly needs to include a process for your staff to feel heard and that they will have the necessary support to do the work that you'll need them to do for growth. Thank you.
Thank you. Peter?
I would just quickly take the opportunity to mention that some of the greatest need for PACE is in rural areas, and though PACE originally started out serving primarily urban areas, we do have a number of programs, I want to say approximately 16, that are serving rural areas, and we find that often that is where the greatest need is. We have rural programs that are now serving close to 30% of the people in their communities who need long-term services and supports.
Thank you. Amy?
Great. I just wanted to reiterate that there's an untapped opportunity to spread PACE, which is it's an already proven model of care that both improves outcomes for seniors and also lowers costs. So if you're interested in supporting the PACE program, let us know.
Thanks so much. I want to thank Amy Herr, Tom Ryder, Peter Fitzgerald, and Ursula Robinson for their presentations. I also want to thank West Health and the John A. Hartford Foundation for the support of this webinar and our continuing webinar series. We will be making today's presentation available to anyone who wishes to view it later, including both the slides and the audio. Please watch your email if you registered for this program to be sent within a few days. And finally, we want to thank all of you for participating in today's webinar. Have a great day.